Hey, nursing students, we're going to review burns today, specifically severe burns that are more than 20% total body surface area, and we're going to talk about the changes that happen during the emergent phase. All right, so we're going to start up here. When you have a burn that's more than 20% total body surface area, the body is going to go through a hyper-inflammatory response systemically. So this isn't only going to be localized to where the burn injury is, this is going to happen from head to toe. And part of that hyperinflammatory response is going to be increased capillary permeability, which means that our vessels are going to become very, very leaky. Next, we're going to get acquainted with this picture here, and don't worry if you can't see it because I'm going to zoom in. Okay, so this picture here, this orange line depicts our skin. Okay, and this is a blood vessel. So this is our tissue, our skin, and then a blood vessel. During the emergent phase of a major burn, the patient is going to experience a massive fluid shift, and that is partly because of that increased capillary permeability. So the patient's going to go into hypovolemia. That fluid is going to leave the vessel and travel up into the tissues. This is going to cause edema. And remember, this is a systemic response, so they're not only going to get edema around that injury, they can potentially get edema from head to toe. We're going to think about airway, because our airway, if it is surrounded by edema, then we can lose our airway. We also want to be concerned about compartment syndrome. So this is from all of that pressure kind of squeezing in on our vessels and our nerves. So massive fluid shift. Fluid is going to leave our vessels into the tissue, cause lots of edema. So next, once that fluid starts leaving the vessel into the tissue, it's not only fluid that's leaving. So protein, albumin, that is usually in our plasma, is also going to follow the fluid and head into the tissues. Sodium goes where fluid goes, so we're going to have lots of sodium traveling into the tissues. White blood cells, they are going to also follow the fluid and go into the tissues. So that's going to leave us with low albumin levels, which is going to make the problem worse because albumin helps to regulate oncotic pressure in the vessels, which means this is going to create even more leaky vessels. Sodium, that's going to leave us hyponatremic. White blood cells are going to be low, leaving the patient even more at risk for infection. With a major burn, we're also going to have many injured cells. So injured cells, when they break open or lyse, are going to spill all of their contents into the bloodstream. So as we know, potassium mostly resides inside of our cells. So if we have all of these injured cells opening up, they're going to dump all their potassium. So we're going to have hyperkalemia. Also, myoglobin from those muscle cells, protein from the muscle, are going to spill out into the blood. So much so that we might even see it in our urine as tea-colored urine. This massive fluid shift is going to leave the patient hypovolemic, and we're going to have thick, sticky blood. This is going to lead to poor perfusion to all of our organs. This is also going to leave the patient at risk of blood clots, so we need some type of VTE prophylaxis like heparin or Lovenox. This poor perfusion is also going to cause decreased oxygenation and decreased cardiac output. So the body is going to start to prioritize vital organs, and guess what? Our GI system is not a vital organ, so the patient may develop an ileus. Now let's go back up here to where the burn happened. So we have impaired skin integrity here. And because of that, the patient is going to have a difficult time regulating their body temperature. So they will be cold. So we have to make sure that we keep them warm. Also, when you have impaired skin integrity, our barrier has been disrupted. So the patient is at high risk for infection. All right, so let's recap. We are going to have an increased hemoglobin and hematocrit because of that super thick, sticky blood. We're going to have hyperkalemia from all of that cellular injury. Same with myoglobin, it's going to spill into the blood and urine. We're going to have an increased BUN creatinine because our kidneys are going to feel the effect of that hypovolemia, and they'll likely start to go into acute kidney injury. We're going to have hyponatremia, low albumin, low WBC, because these items will be following fluid into the tissues out of our vessels. This is going to cause metabolic acidosis. So that lack of oxygen circulation, the body is going to starve. It's going to find another way to get oxygen, and it's going to produce a lot of lactic acid. Body temperature is going to be low, so we want to make sure that they stay warm. They will probably need an NG tube because that GI system is going to be slow moving. And we want to keep strict I's and O's, so this patient needs a Foley. And thank you for watching. Like and follow for more. Bye.